Wonderful. So thank you very much, everyone, for joining us for this virtual dialogue on palliative and survivorship care in UHC. This is the final session in a series in which UACC has been exploring different aspects of cancer control and in their inclusion in UHC with expert speakers from our membership around the world. And we're delighted that you're all joining us today. Before we kick off, a little bit of housekeeping. This session will be recorded for those of us who aren't able to join live due to summer vacations and time zones. If you do have any questions, please do feel free to drop them in the chat, in the Q&A function, or when we move to open discussion, you can raise your hand and I will unmute you directly. So without further ado, it's my pleasure to kind of open up this conversation. And I think from the starting point, UHC is really about kind of responding to the needs of individuals around the world. And we know that given that it's the second leading cause of mortality globally, UHC cannot be achieved without the inclusion of cancer. Palliative and supportive care are a core pillar in how we do cancer care and cancer control. And it's such a major part of every cancer patient journey that we really need to make sure that it's included within those UHC benefit packages. But from the data we currently have, we know that palliative, supportive, and particularly survivorship services are often missing from those benefit packages. That being said, we have a suite of cost-effective interventions, and we've got this growing body of guidance around how it is that countries can put a lot of these mechanisms into place. So our conversation today is going to bring together three expert speakers from around the world. I'll introduce them to you all as we start the conversation. And one of the key things we want to do is really learn from successful advocacy so far, where have we got and where do we want to be going in the next few years? And so once we get to the Q&A section, we'd also like to pose a question to everyone around the call, which is what would you like to see change by 2030? So I'll leave that with you all as we move into the conversation with our expert speakers. And it's my pleasure to turn first to Chris Cheng from SCAN, which is the Society for Cancer Advocacy and Awareness in Malaysia, based in Borneo. Chris, thank you so much for joining us today. We often see quite a strong focus on cancer treatment in UHC discussions, but I think this can sometimes miss out on the essential part that is supportive care services that really underpin the ability of patients and families to make it through their cancer journey, and really kind of are the foundation on which a lot of these key interventions are built. I want to sort of open up the conversation with you, and what are some of the common challenges you've seen in patient access to supportive care? And can you tell us a little bit about some of the work that SCAN's been doing to address some of these?
Thank you, Rosie, for having me. First of all, yes, you're right. Cancer is just more than treatment of the disease itself. When a cancer patient first have their diagnosis, they're immediately filled with all sorts of strong emotions, fear, stress, anxiety. They can get overwhelmed, they can get depressed. So this leads to the first issue that I see that's lacking, at least in my neck of the woods, which is a lack of trained counselors in the hospitals itself. There are some counselors, but they are also not being referred to. The doctors are not trained to refer patients, or they don't see the patients as needing help yet. But patients will feel all sorts of emotions. I know I did when I first started. But I didn't know where to go. There was no pathway for me to seek help. And there's still this taboo of mental health taboo in Malaysia. So you don't really go and seek out counselors in the first place. Even other helpful interventions like yoga, art, music therapies are not really provided. So it's very rare for patients to be referred to counselors, psychologists, or other mental health professionals, or getting to these helpful treatments, helpful activities that might help them ease their journey through their cancer. As for one of the things SCAN has done is to have a peer support. Before COVID, we actually have it face to face, and after COVID, we had to pivot it online. And we also have survivor sharing sessions, which we are moving back to face after a couple of years of having it purely online. And this is where survivors or current patients get to share their experiences, share what was helpful for them, and different things, even simple things like exercise. How do you exercise under treatment? That also helps. That also gives you that patient that grounding in order for them to feel better about themselves as well. Plus, exercise usually helps during treatment. Another place lacking is actually patient navigators. New patients are usually lost not only in terms of their emotions, but actual information on where to go, what to do. I remember the nurse just telling me, here, go take your blood at the lab. I didn't even know where the lab was. So you have to navigate yourself through, the inevitable size of that hospital. I believe all hospitals tend to be a maze of some sort. So you get yourself from your doctor's office, doctor's clinic in one point A, and then to the lab and back. So if you have some sort of patient navigation service, and currently SCAN is not providing, but there are other NGOs in Malaysia that are providing patient navigation. And I believe in Philippines it's the same as well. They have good patient navigation services, and it helps. It helps reduce the default rate as well. We also find there's also a lack of palliative services in Malaysia, in Sarawak, especially in Sarawak, where I'm from. Like, there's only a 9-bed palliative ward. The palliative specialist only came in December 2021. Before that, there was no palliative specialist. So the domiciliary visits, few and far between, usually handled by other palliative NGOs, not by the government itself. And from what I've heard, if you are staying outside of Kuching, which is the capital of Sarawak, where the tertiary hospital is, getting your operates also gets significantly harder. So those in palliative care, they would still have to somehow get themselves to the hospital to get their operates. It's harder for them to get it to their home. And one last issue, I hope I'm not taking up too much time, is that survivorship issues post-treatment are also seldom addressed. I myself am a cancer survivor, and there's always this sort of Damocles hanging over my head, wondering, is this cough just a normal cough, or is my cancer returning? Every time I go for a scan, which luckily it's getting less this time. Previously, it was like once a year, but I digress. You get what I term as a scanxiety. Every time you go for a scan, a CT scan, even an X-ray, and so on, did they find something? Is this cancer returning? Even when I talk to other cancer patients that have had their cancer for more than 10 years, 15 years, they still face that anxiety. It's still in the back of their head. The other issues, long-term side effects, things like fatigue. I myself still face some uh, issues from my stem cell transplant. I still have some graft versus host disease. My skin's dry all the time, but I've seen people have worse. Uh, yeah, after stem cell transplant, they still have ongoing issues 10 years, 5 years, 10 years down the line. I mean, we are all grateful that we are well, but these are ongoing issues, not to mention those that have chronic cancer. The cancer is being treated like a chronic disease. Our founding president is a metastatic breast cancer survivor. She's 6 years in, and she still has to face a lot of issues with her ongoing treatment. Another one that I've starting to dig into is workplace issues. Getting back to work can be an issue, especially if you do have long-term side effects like fatigue. You will be able to handle yourself at work, going back to the same working hours as before cancer. Some get discriminated because they know that, oh, this person has cancer or had cancer, maybe it will return. Maybe she can't work as hard as before. These are some of the issues that I've heard of for cancer survivors post-treatment.
Fantastic.
These are just a few.
Thank you so much, Chris. And I think you've done such an excellent job of resumeing so many kind of complex impacts, as you were saying. And as in everyone's cancer is different, the impacts they're likely to feel through and after their patient journey are also going to be unique to them. SCAN is also an excellent advocacy organization. So I wanted to ask, what kind of opportunities do you see to help change or improve patient support services in the midst of these UHC discussions? So we've got negotiations going on through to September, and then after September, when the political declaration gets adopted, that's when the real work starts in terms of trying to get things implemented. So are you hopeful? What do you see any opportunities, and what's your take on it?
I think it's a must to have mental health included inside UHC. It's not only for cancer patients. I think mental health issues are on the rise. In Malaysia, we do see a lot more suicides, a lot more depression going on even among younger adults. So this will not only benefit cancer patients, who we all have our issues as well, but also the population large. So it's a no-brainer to add it in. It's no-brainer to ask for this. I've also asked that they look into supportive services like patient navigation, palliative care services included in UHC as well. Because it's not, like you said, Rosie, it's not just about the treatment. Cancer is about the person as well. So you have to treat the person, not just the disease. So those are my thoughts on what we can add into the UHC discussions.
Thank you so much for that, Chris. That's really great. And you've teed up perfectly our next speaker, who's Dr. Christian Zamira, who's a palliative care physician with an interest in global health and social medicine, and who's currently the executive director at the African Centre for Research on End-of-Life Care. So Christian, thank you so much for joining us this morning. Chris has given us a great introduction to the supportive care space and has sort of touched on some of the palliative care elements as a key part of within that kind of spectrum of work. I think one thing that many people will be aware of are the huge differences, the huge inequities in being able to access palliative care services around the world. And Chris touched on that in terms of kind of being able to access home-based care, the recent development of a palliative care unit. And so I kind of wanted to open up with a question with you, how does palliative care fit in within the package of cancer care services? And, you've been doing a lot of work on building patient-centered care services. What do we need to bear in mind? What do governments need to bear in mind when they're looking to develop this within the context of UHC? Kristen, you might be on mute.
Sorry. Sorry. Good morning, everyone. Thank you, Rosie, for having me for this dialogue. And thank you, Chris, for this great testimony. And I think one of the biggest challenge we have in cancer care, when you mention palliative care, is the misunderstanding, because people think that palliative care equals end-of-life care and terminal care. And we are still struggling, not only in Africa, but around the world. When I'm traveling, people are still thinking that when you mention palliative care, that means the patient going to die. But the good news, we all die one day, but we live every day. That is really important. We need to understand. So, and the integration of palliative care in universal health coverage, starting by the understanding. When people understanding well what they need and the role of palliative care, then that will push people to invest. But if people don't understand even the meaning and the role of palliative care, we'll be struggling on the journey of integrating palliative care in most of public health system. This is my opinion and my experiences on that. So the second point is about contextualization. We can develop a palliative care model which fits for all people. For all around the world. That will not be possible because our understanding, our community is totally different. Let's say, for example, in Rwanda. In Rwanda, we have, in social context, we have a saying, when you are well, you belong to yourself, but when you are sick, you belong to your family. So that will be crazy to ask people from Rwanda to develop a patient-centered model, because our understanding is not patient-centered model, it's a community-centered model, because the patient is part of the community. The patient is not isolated out of the community. So it's not about the patient autonomy and then you have the community responsibility. It's both. So we in our understanding, we have the patient autonomy and the community responsibility in terms of decision-making. The intersection of both, it's really important. It's not that patient-centered excluded community responsibilities. So if we need, in the line of universal health coverage, we understood that we need to combine both. We need to combine the modern medicine, we need to combine the traditional approach, because we cannot connect community without connecting identities. And that is really important. And palliative care, the philosophy of life and death, is really connected or reconnected to the identity of the person. And we need to take the person as a very unique, as Chris mentioned, you can treat the disease without treating the person. But if you treat the person, you must treating the disease as well. So that is, for me, from our experiences here in Rwanda, even including palliative care in public health system, was really to understand about the uniqueness we have, that consider a person as one, a human being, second, connecting to the identity of the person, and reconnected the patient with the social culture perspective, which is, on my understanding, really important. Because as Chris mentioned, it's not only about the disease, because the disease is part of the person, but it's not the person who is part of the disease. So that is, and it could be a temporary status. So we need to be clear on that point. So this is, I think, on my my understanding and perspective, and what we are doing now, and continue to advocate that, sometimes international standards could be a source of inequity and social injustice if that will not take into account some of a critical point which is related to the identity and social culture of the person.
Fantastic. Thank you so much for that, Christian. And I think it's a really powerful point that you were saying, that, a disease is part of the person, but a person is not part of the disease, and the care we need to give must respond to those individuals. So with that in mind, I'm going to ask you a really difficult question, because it's going to go from what the individual needs to how we build a system that delivers what the individual needs. And what is it that you want to see change under UHC? If you had a Minister of Health in front of you who was saying, right, I want to do more on palliative care, what would your advice to him be? Like, how should countries be making progress, or is there a standard model?
Yeah, I think the model, it's a difficult question, but I want to answer a very simple one. I think because this is the work we are doing now, because our organization is partner with the Minister of Health to support the Minister of Health and the Rwanda Biomedical Center to continue to implement palliative care program. And one thing we learned from the COVID-19, the pandemic situation, was to not repeat the same mistakes, focused on the modern palliative care base for external fundings, because we saw something really during the pandemic situation when funding or money withdraw during the COVID-19 and every activities and most of the projects in palliative care stopped. But care continues. And that was really interesting, even if external funding stopped, but care continues. And it was really interesting to understand why Kenya continues when external funding stops. And just we realized there is deep in community resilience based on the compassion and empathy from the community. So from answering your question, and this is what we are doing, it's not more about we just training people, educating people about palliative care because about the man understood, but it's to create a model in which adapted and adopted by the community and really focus on our needs, because the needs could be totally different. In physical, yes, it could be the same. If you have a pain in Rwanda, you have pain in Australia, it's still physical pain. But social pain, psychological pain, and spiritual pain can be totally different. It's based on the perspective and perception of life and death from different communities. And if we need to build a system, we need first to understand from the needs of the population. So it's now what we are doing now is creating a sustainable model based on our current realities in Rwanda, and especially focus on treatment, time, distance, and cost, and making sure the treatment is really integrated, because time, we need to make sure that the patient will get access. The package could be different from one setting to another setting. In terms of this thing, palliative care can be accessible at each level, and also integrating traditional approach or social culture approach, and making sure that also will be part of the policies of the Ministry of Health, because we find that from the COVID-19, the experiences we learned that if care continues during that time, so we need to understand, we need to do research to understand more why care continues and what is the resilience came from the population. And that was not financial things. It was really deep included in the DNA of the population, that we are together, we need to fight together. And it's not about I, and it's not we. And this is what now we are doing our research about the one of the strong philosophy rooted in the African continent, the Ubuntu philosophy. I am because we are. People are people through other people. So I think in some place when we neglected compassion and focus on oh no, people need more equipment and blah 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 and everything, yes, that is really important, but what makes people resilient to continue to take care of other people even without with limited resources, it's compassion. And I think it's something we need to invest more in universal coverage and developing some metrics to understand more how compassion can drive the society and make a change. It can be a game changer in cancer care.
I love the idea of a policy led by compassion. I think that seems like the most beautiful approach to policy making in cancer control. And thank you so much for that perspective, Christian. And it's really interesting to hear about some of the research that you've been doing around kind of how services continue even in the absence of resources, and how important kind of that community-centered nature is. You've also very beautifully teed up Nicole, who's our next speaker. So Professor Nicole Henniker is Associate Professor of Prostate Cancer Partnerships at the University of Southern Queensland in Australia. And Nicole, thank you so much for joining us today. We've heard from both Chris and Christian about the importance of wrapping services in and around patients with communities. and how, you know, this kind of bubble, this kind of network, as you were, of compassion is so important. And I think we've seen this a lot within sort of broader patient support services. Christian's give us an excellent idea about how it, you know, is the driving force behind palliative care. But we've often hear a bit less about kind of survivorship care, and Chris touched on some of the challenges that are being faced. And so I wanted to ask you to maybe share a little bit about the framework that your organisation has been helping to develop, and what are some of the key components of survivorship care that we as advocates and people around the call should be aware of?
Great. Well, thank you, Rosie, very much for the opportunity to speak to this today. And what I'm noticing already is there are some really lovely synergies between the survivorship care and what Chris and Christian have been talking about. There are actually some really profound overlaps. And so we have done quite a bit of work developing an evidence-informed survivorship framework. Over the years. It started initially in prostate cancer, but it's really now expanded to cancer generally, because one of the things that we found was that a lot of these domains and concepts are not cancer specific, but it is very much about you know, the care of the person, their family, the community. It's a really integrated approach to survivorship care. So I might just take a step back before I go into the details of the framework, because I think similar to what Christian was saying, survivorship is a concept that is often not well understood, and there are often, you know, different definitions of survivorship across different countries, but also across different cancers. And the definition that we have adopted is that survivorship care begins at diagnosis and it extends all the way through to the end of life. And so that captures anyone with a current or previous diagnosis of cancer, someone who has, you know, cancer right now and is dealing with treatment, someone who is considered cancer-free, but then also when you're looking at things like the monitoring and, you know, the vigilance required, the surveillance required to monitor the cancer, and then also cancer recurrence through to that palliative and end of life stage. So it's very broad. Critically, our definition of survivorship, it focuses on health and well-being, the physical, emotional, spiritual, social, and financial. And again, both Chris and Christian have spoken beautifully about how, you know, this is not just a physical disease. It's also not just about one person. It has impacts on the family. It has impacts on the community. And, you know, so correspondingly, we need to really take a broad approach when it comes to survivorship care. So survivorship by its definition includes family, friends, and caregivers. It includes the broader community. I think one of the interesting things with survivorship is that it's not necessarily a term that resonates across different cultures and different languages. It can be, you know, the way we use it in English-speaking countries can be quite foreign in other countries. You know, it may be that a term like well-being is perhaps a little bit more general, but the really important thing is that it's about the well-being, the health and well-being across that cancer trajectory from diagnosis, and it really needs to be contextualized to the local context. So with that in mind, as when we developed our framework, one of the most important things for us was that there was a really, really strong consumer voice. A lot of the time when these frameworks are being developed, there's an over-reliance on expert opinion. And so the panel that we had put together, 1/3 of those participants were consumers. And, you know, we just got such fabulous insight into what was important for them and their previous experience and how, you know, not ideal their survivorship care experience had been previously. I think anyone, you know, really thinking about implementing and integrating survivorship care as a concept into cancer care, you'd be ideally going with an evidence-informed framework, because that will give you some guidance. But it's really important that the framework is not just robust, but it's easily translated into policy research and practice. So it needs to be, you know, easily used, easily understood by all the stakeholders that are involved. And it's a really diverse range of stakeholders that are involved in survivorship care. And I think one of the things, and again, I'm echoing both Chris and Christian here, is what we really need to recognise is it's absolutely not just the biological and physical aspects of cancer that need to be considered when we're looking at anything like this. It's the impact on the whole person, the person, their family, the whole community, and critically, it is that psychosocial component as well as the physical.
Excellent. Thank you so much for that, Nicole. And I think you've picked up on some really great themes, as you say, that have emerged so far. And I really like, that both the work that you've been doing and that Christian's been doing has been looking at kind of how we build a framework around that. Because I know that if for people who haven't gone through that journey or haven't necessarily seen a loved one, whether that be a family member or a friend or a member of your community, go through that journey, you can't always understand obviously the physical, but the social, the financial, the spiritual components to that kind of that journey. And I think maybe a similar question to the one I posed to Christian, which is, we talk a lot about the progressive realization of cancer treatment services, this idea that we build up over time towards a kind of an end goal. And so if you had the Minister of Australia or the UK or any country in front of you, what would you like to see being included as countries better plan to implement survivorship care or wellbeing care, however you want to frame it, and what opportunities do you see?
Well, I think, one of the key statistics, and this is, I think any minister needs to hear this, is that our cancer incidence continues to grow globally. We have a growing and aging population. There have been profound changes in the prevalence and distribution of cancer risk factors. And in the next 2 decades, we're looking at approximately 30.2 million new cancer cases, which is over 50% of what we have now. So from a survivorship perspective, the number of cancer survivors is growing exponentially. But really importantly is that there is an immense global diversity of cancer survivorship and the lived experience depending on where you are. And again, I touched on this earlier, while there's a lot of progress in cancer treatment and subsequently cancer survival, it's really important that, along with these biological momentum and change, we actually keep pace with the psychosocial perspective as well, and that the provision of psychosocial care is routine and embedded and is alongside any physical treatment and physical care. And that's things like routine assessment. I know Chris mentioned that just the challenges of even connecting a patient with, say, a counsellor or a psychologist. And ideally what we would like to see is every patient is routinely assessed for distress, for the psychosocial impact of the cancer, and that will change depending on where they are in that survivorship trajectory. I guess, again, similar to what I mentioned earlier, we need to be clear on our definition of survivorship, but it also really needs to be prioritised. Now, what we see is globally, if a country has a national cancer control plan, they may have a corresponding survivorship plan. Survivorship plans are not necessarily embedded within cancer control plans, but what we certainly see is in countries without a national cancer control plan, there is generally, there's no aspect of survivorship that is embedded in any kind of plan. So it's a massive gap. Ideally survivorship becomes just, again, a side-by-side component of any cancer control plan and more broadly. And similarly, when you're looking to develop a survivorship plan, you would probably follow those same principles as the development of a robust national cancer care plan. And that's, acknowledging survivorship as a key domain in the cancer continuum of care, which is why that definition is really important. Adopting a health systems approach so that you're really clear on things like governance arrangements, resource allocation, financing, and measurable survivorship goals, and then sustainability, a sustainable strategic plan that again is contextualised to the country's cancer burden, socioeconomic environment, and also the healthcare system, as well as the resources that are available to implement the plan. Because I think what we've heard loud and clear from both Chris and Christian is that it's very different for different countries, different cultures, where you are globally. There is no one size fits all. There is no one approach. So we need to be agile, and we need to always have that local context and those local needs first and foremost. And ultimately, anything we do needs to be underpinned by an evidence-based approach. There's a wide variety of survivorship interventions that have a strong evidence base behind them, that are financially viable. These are the priorities for getting into a cancer care plan. And again, I keep stressing this, but it's not just the physical stuff; it's the psychosocial stuff as well.
Fantastic. Thank you so much for that, Nicole. That's really great. And I think, as you say, actually thinking of supportive care or survivorship care or palliative care as a key domain within cancer control. I think looking at the broader NCD landscape with the excellent advocacy that's been done by organizations like Kristen's, yourselves, we're starting to see kind of that supportive care element much better included for cancer control. And it's interesting that there isn't quite the same resonance across other necessarily disease areas. But I think that means we've made the first step in that path, and there's a lot much further to keep going. I wanted to sort of open things up a little bit to our participants on the call as well. So if anyone has any questions, then please do feel free to drop them into the chat function. I've been sent one or two, so I'll kick off with those and give everyone a little bit of time to also reflect. And Christian, it kind of picks up on something you were saying, and Chris as well, around the impact of COVID-19 on a lot of the kind of support services. So we saw a lot of support services change, reform, or get rolled back over COVID-19. But the question is more around, how have governments and health planners changed the way they're thinking about palliative and supportive care, particularly given the burden of things like long COVID? And do you see any kind of similarities to sort of build a bigger movement behind palliative and supportive care? So Christian, I might come to you first because you've been more engaged, or you mentioned COVID-19 research first, and then I'll come to Chris and Nicole, just to put you on the spot.
Thanks, Rosie. I think, yes, the COVID-19 was, challenging everywhere in the world, and especially for low and middle income settings, because access to vaccine was also challenging compared to global north, struggling global south to get access to vaccine, access to the right information, access also to equipment. I think from all those struggles, the good thing is every government, try now to understand better, because I hope this, I'm not sure, but I'm not sure that this will be the last pandemic. I'm not predicting another pandemic, but it seems like we need to be prepared for a different situation and challenging, where maybe our sort of health system needs a change, or need to be more innovative to making sure that for any difficult conditions, patients will continue to get services. And it's in that context, in Rwanda, the program was started many years ago, but now through the COVID-19, and it's now the government is trying to strengthen it. Now it's using community health workers and empower families and the patients to be not only, the consumers, but also to be the decision makers on that. And I found it really interesting when I was mentioning about the model we now developing in palliative care. Now it's imperative, when we train physicians and we train nurses at the hospital, we need also to train community health workers at the same time. It's a different package, but it's the same level of training, really focus on, for any situation can happen, community health workers will fill the gaps. Even patients and family caregivers will fill the gaps in that context. And also for the government now, how they can invest more in at the community level, and trying to find a different mechanism of funding, and not necessarily rely on external funding, and try to see how patients will be really involved on that. And one of the good program here in Rwanda is the medical insurance. We call it the community-based health insurance, where the patients pay only 10% out of pocket, and the 90% reimbursed by the government. So that's reduce, the inequalities between social inequality, social categories between people, but even the poorest people can get access to the best services on that context, and that's creating a resilience in the community, and everyone is involved, because that's benefit to everybody. And it's not all the population will get cancer, but for those who will be diagnosed with cancer will get at least access to treatment, and also for others, based on cancer control and prevention, all information will be available. I think that was the key lessons learned from the COVID-19, and really focus on the community. We need a shift, a paradigm shift, and taking the community not as a consumers only, but also part of the decision making.
Fantastic. Thank you so much for that, Christian. And I really like the point you were making around kind of, having consumers and people receiving care being consumers and decision makers. Often I think it gets referred to as kind of empowering people, but that makes it sound like people didn't have the power already, but it's more bringing them on board and making sure that their voices are listened to, and much more part of the response. Chris, could I maybe come to you and get your thoughts on has COVID-19 and the impacts of COVID-19 sort of changed how people think about the services that the scan provide and the advocacy that you've been doing? Have you seen a change in any of the approaches or mentality?
Actually, I would like to say yes, but I think people are trying to put COVID behind them. So you see people trying to get back to what was the previous normal. So we've begun to see that for our events, face-to-face is now more preferable than before. But I do see that people begin to appreciate the frontliners more, the healthcare professionals more. So that is of course good. But whether the government itself, our government itself, will be able to add in more psychosocial support services remains to be seen. Lack of funding would be one of the major issues. And yeah, whether they can make the whole system a bit more agile to be able to fit that. In terms of NGOs, yes, on our side, funding also becomes a major issue. I think not only to SCAN, but to other NGOs, especially those in palliative, that provide palliative care services. One of the major concerns they have that they shared with me is funding. And this is post-MCO, post-COVID. So you would think that the general public will be more supportive, but doesn't translate that way, unfortunately.
That's really helpful to be aware of. Thank you so much for that, Chris. And I think it's interesting. We saw obviously with COVID huge demand for palliative and supportive care services going up, but actually that, as you say, maybe people are trying to put COVID behind us and sort of returning to the way things were, almost as a reassurance, not necessarily as a sort of a conscious decision. Nicole, I wasn't sure if there was any comments that you wanted to respond as well.
Oh, look, just interestingly, I think in Australia, what happened was the COVID really facilitated a shift to telehealth, and that for our very remote and rural populations was a great boon, because really that's something that has been sustained since the pandemic. And I think one of the positive impacts was people are more open to telehealth, but also more open to innovative models of care. There's, things like virtual care, I feel, are getting a little bit easier the acceptability of virtual care is higher. There are really interesting virtual care models being developed in terms of patient monitoring. And what we're really seeing now is a shift towards, psychosocial care delivered virtually as well. And, we've seen some fabulous results with that. So was just one thing that came to mind, probably not quite as specific as the question, but we've definitely had some positive impacts in Australia.
Fantastic. Thanks so much for that, Nicole. And Christian, there's a question directly for you, but open to the whole panel if you'd also like to respond. How can we get allied healthcare workers to understand that palliative care is not about giving up? It's a continuation of care symptoms for the control for the patient and family.
I think we need thanks for the question. I think we need to move from the biomedical perspective to the biosocial approach in medicine. And it's my understanding is this part of medicine have been lacking, and this is why all challenges we have now when we mention about palliative care come from this perspective on a bio. The biosocial, the biomedicine have been so rooted in the way we treat the person, and we just forget. We just forget that some realities that we are treating person. We are treating person and the environment of the person, and it's something really important. Advocacy, training, education need to continue, and also contextualize it, because that's something really important. I try now to teach people that we need to contextualize, because if you try to duplicate a model, let's say, for example, Nicole, allow me to use Australia, but nothing. Yes, if I'm trying to use something from Australia and duplicate it in Rwanda, that will be really difficult, even if you know the reality. Some experiences in Australia could be really good and say, oh, we'll be happy to have A, B, C, D. But in our context, it will be totally different. I'll be struggling to use this kind of palliative care program in Australia and try to duplicate it in Rwanda. So, and my understanding is education doesn't mean duplication. It's rather than adaptation. We need first to adapt. We need first to adopt and then to adapt. You adapt to the local perception, then you adapt to the current challenges instead of just duplicate one model to another. And my experiences in Africa, most palliative care model we have in Africa came from Euro and American and Euro culture experiences. And we are still struggling in Africa to develop our own palliative care culture. And this is some of the challenges we have, because it's really, let's say, for examples, when I'm sharing with people, in Rwanda, we don't talk about death. We talk about life until the end. It doesn't mean people don't think about death, but people think about life until the end, because every life deserves to be lived until the last moment. And when people are focused on life, even if it's 1 second, 2 months, 10 years, 20 years, it's about life. But in all the culture, people talk about death, good death, bad death, everything goes focused on that context. So you cannot try to just duplicate it and bring, without contextualize it on that context. And I think, because my understanding is global is local as local is global. So if we need to create that global understanding of palliative care, which will be reducing stigma and misunderstanding, we need first to understand our local perspective. We need to bring our local perspective on the table. Then we'll create a global way of understanding in palliative care.
Fantastic. Thank you so much for that, Christian. I think that was, yeah, no more comments. It was an excellent, excellent response. Chris and Nicole, is there anything you'd like to add?
I just have sort of a question, because it seems that people all around the world have the same way of viewing palliative care as just an end of life care. So I was just wondering, is this just a question of branding? Maybe Nicole or Christian, you can shed some light. Sorry if this was a simple question.
Christian, I'm going to let you have the first go at that one.
Okay, Nicole. It's deeply rooted on the first movement of palliative care, the modern movement of palliative care starting in the UK, which was really focused on compassion and included palliative care. But I think the transition between the modern to other countries has been, it was one of the challenges on that context, when people was trying to duplicating the same model and then the understanding, because that was becoming and more struggling people to understand that palliative care is part of care. They're thinking in the beginning of the history, if you, I hope I'm not mistaken on that, people who have end-of-life care was really just putting on an isolated place and waiting to die. So it means that image has been transcended over and over decades, and people still keeping on that mind. When you mention palliative care, it's like you need to be isolated place and just need to die. And now the context is changing. And unfortunately, most of medical curriculum and nursing curriculum are still focused on the same trends, that people, you need first, if someone have a cancer, you need to treat cancer, you need to make sure they have a best treatment. And if it doesn't work, send the patient to palliative care. So, this kind of language you can hear everywhere. And if you see the definition of palliative care, you need to start palliative care at the beginning of the diagnostic, because it's about physical, social, spiritual, and social. And that to continue to work with the patient on that journey and their families, on that context. And if it's trending, branding, I'm not sure, but my understanding when I'm saying we need to move on by social, that means historical perspective matters. So if we understand better the historic perspective, then we'll be able to change on that. As long as we are not focusing on, my wish is, I hope we can have a global solidarity of global funds of cancer and palliative care. I'll be happy to have a global fund of palliative care and cancer. But in case it's an illusion or an utopia, let's first learn from our historic perspective and then see how we can change the trend, how we can give. Now we have more and more access to tools and resources to change, the perspective and understanding on that, and give more quality of life of our patients and their families.
I think also, Christian, I really like what you're saying about the contextualizing to a local context and models working and not working. And Chris, in terms of what you're saying, I think that, again, the language and the terminology is really important, and having the conversations, and it's also about normalizing. The more we talk about it, the more it becomes part of everyday conversation. There isn't a stigma around it. And it takes a long time. We've done a lot of work in Australia around, reducing the stigma of the terminology around palliative care. It takes a really, really long time. But it's about having those conversations. It's about, assuring people this is normal, correcting misinformation and misconceptions. But unfortunately, I think that's something that you have to keep working on it. It's not a slow change.
Yeah.
Fantastic. Thank you all very much for that. Jane, I wanted to come to you for your question.
Thank you very much, Rosie. So I wanted to first maybe just even give a shout out first. Chris, I really loved the idea of the patient navigation. And maybe let me just say that, you know, that I'm a lawyer by training, but I'm also a survivor. And actually metastatic breast cancer stage 4. And so those terminologies that you're talking about around, you know, Chris was talking about the palliative care. So when you're in stage 4 and they say to you, well, obviously you're quite advanced, and so we'll get into palliative care. That sounds like we're going to put you out to pasture somewhere. And I love the idea that palliative care starts from the beginning, because that's what my doctor said to me. Do you want to fight or do you want palliative? And of course, I'm like, I'm going to fight. You know, so the terminology stems also from science, because I mean, that's what we are receiving as patients. And so the misinformation must start, I think, from that context. And I really like the idea of those concentric circles around care, you know, that person-centered, but it's community also centered, and that's a resilience and strength factor. But the question that I have, because what I'm getting involved in, being a lawyer, you know, and we have to fight, has to be around what I'm calling medicine, equity, and justice. So the issue of medicine and treatment is a big issue for us in Africa. And Christian, you talked about that. We saw that even during COVID. The issues of access of vaccinations and medicines and essential lists and things like that. So when you're dealing with cancer care, for example, you have that issue about accessibility of medicines, even if you can afford it. And then we have the issue of, even if you can afford it, you know, what's the quality of what you get? And so my issue also was that when you're looking at, even from the beginning, when you're making medicines, there's a lot of trials that go with it that contextualize our bodies genetically, our environments. And when you see that we are not having any clinical, or less than 1,000 clinical trials in Africa, then those medicines are being made outside of our context and outside of our environment. And then we have all these incidental issues that we have. You know, medicines that have, you know, they cause dental issues. So we're always having issues like that. Medicines that cause a higher rise in diabetes or hypertension. We know that Africans are predisposed to some of those ailments, particularly hypertension. So how are those things contextualized? So there's the one of access. So can we get what's there? Number two, you know, can we start thinking about how we contextualize it in medicines, even to our own context, our genetics and our environment? Thank you.
I think the question is for Nicole.
Really? Because I have to admit, I feel this is quite out of my scope, Jane. I don't really know how to answer that question. I'm sorry. So I don't know whether Christian or Chris have some insights there. But just to acknowledge that, yes, I know that the access to medicines is a huge issue, and then also as you're mentioning the you know, I guess that disparity in terms of number of clinical trials and really being able to test and evaluate in a local context, it is just so critical. But unfortunately, I have no answers for you at this point.
Thank you, Janet, for for the good point, I like the way you develop it and came from your personal experiences. And this is, changing even the narrative. It's something really important we need to learn from those narratives to understand what will be the best way and best decision will be taken on that. And you mentioned a very critical point, access to medicine. How can we do that in Africa? And that we'll engage stakeholders. And the experiences, from the COVID-19, after, the struggle from global north to get, to bring access to a vaccine to global south. And after the COVID-19, I see now more and more African countries, they said, we need to have our own manufacturer, our pharmaceutical manufacturer in the continent to make sure we will produce our own vaccine, our own treatment based on the best of quality. And all our population will get also as the best as, the global north. But in that term, so you have many challenging in terms of pharmaceutical company, funding, who will be funding that, which government will be able to invest on that, and how much investments will be. You mentioned about diabetes, hypertension. For NCD perspective in Africa, when it will be grow people with diabetes, hypertension, and access to treatment is really, really important on that context. So we need, my understanding, we need also a global solidarity in that context. We need to remove that aspect that something happened in Rwanda, that is just for Rwandans. I'm in Australia, I'm very safe, I'm okay, but something in Rwanda, it doesn't my business. It's your business as well, because it affects us, it will affect you as well. So if we continue growing on that perspective, and now more government will be able to get access to develop the same resources, infrastructures in the continent, it will be one of the solution, even for clinical trials. So how many people have been trained for clinical trials in Africa continent? How many countries are doing clinical trials? How many pharmaceutical companies can be able to invest in the continent? You have a bunch of challenges, and one part is, as you said, advocacy. It's something really important, and starting to use what we have, because it's easy to build for things we don't have. But I think that is easy. Yeah, it's easy to have a global fund for palliative care. It's easy to have all pharmaceutical company in the continent and producing cancer treatment. It's easy to have a hospital and the cancer treatment in the continent. But what is difficult? What do you use? What do you have we can use starting from that point? And one of the examples we hear in Rwanda, we have a hospital which is partner from the China government in Rwanda, and which is really interesting. You will see 1 or 2 or 3 rooms when Chinese bring their own medicine, and it's proposing alternative medicine from that. I was like, why we need to okay, it's good to have that partnership that they did bring their own medicine, but we have also somehow our own medicine as well. We have also some tradition can be used as well. Can you starting also from our own perspective, what was using and could be able to bring them up until maybe when we'll find, all those infrastructure you mentioned, access to clinical trials and the medicine as well, because we can't just cross our arms and waiting until we have the best infrastructures, maybe in Rwanda, in Burundi, in DRC Congo, and the other countries. That's maybe some patients will be the victim on the waiting way. So, it's part of the dialogue, and thanks, Rosie, for that. It's also to do advocacy. What do we have first? What do we have first in Rwanda? What do we have first in Uganda? What do we have in South Africa? What do you have in Zambia? What do you have in Angola? Can we start from there, then continue to advocate to get the best infrastructure as well in Africa as we have in other countries? So advocacy, dialogue, I think it's as you mentioned, it's and I like it the way you develop it. Thank you, Janet. Yeah.
Can I just add on a bit? Jane, the issue that you're saying is also faced by us in Asia as well. Most clinical research based in the global north, but we know that we humans are diverse, so different populations may have different needs. For example, I think NPC is a bit more common in Taiwan, in East Asians, but very little research is being done. I think Cancer Research Malaysia is trying to do more of local research as well. So trying to do the clinical research, not just depend on foreign clinical research. So sometimes we just have to do it by ourselves.
Fantastic. Thank you so much to all of the speakers on that, and Jane for your question. I think that was a really excellent one. And I know that we saw at the World Cancer Congress last year, there were a number of discussions on how to make participation in clinical trials much more equitable, kind of also tying it to international collaboration on cancer research and making sure that the data that is generated in Africa, in Southeast Asia, in Latin America stays in those regions, can be used by those regions to really help improve the quality and the availability of care. So that we're not seeing kind of the draw of data to like research centers often in the global north who benefit from it, but then making sure that the research then comes back to the communities that participated in it. But that's almost, I think, maybe Jane, a step beyond the point that you were making, that we need to make sure that those communities are actually part of the trials, part of that research, and part of a global cancer community, and not thinking about kind of a few people here and a few people there. We've had one more question that I'd like to pose to the speakers if we can. And the participant who's kind of sent this in says, we've been doing a lot of work to try and dispel some of the stigma and myths and misconceptions around cancer to get people through the door. How is it that we can start to dispel the stigma around mental health to make sure that patients can also access and ask for those services? Super easy question. Anyone like to step forward?
I'm happy to jump in on this one. That it is just such an outstanding question, and it is, again, it's one of those really complex ones. It's like changing the language around palliative care, and I think what I come back to all the time is it's about normalizing, and there are multiple elements of that, and one is that mental health assessment, questions around mental health are a routine part of every consultation, irrespective of who you're going to see, and that patients are routinely distress screened. They're asked about what's concerning them, and that actually is the springboard into connecting people with services. So I think from a clinical perspective, we need that routine integration. I think a really big part of that is actually, embedding and acknowledging that psychosocial care is a legitimate and essential component of the cancer care strategy. Again, that's conversations that we need to have. That's policy, practice, and research that needs to be embedded into. And I come back to, for the patient, I think if patients hear it often enough, if it's a normal conversation, there's a bit of momentum gathered, that is a big part of taking away the stigma around initiating conversation, asking for help. And certainly one of the big things that we focus on with our survivorship essentials framework is that concept of personal advocacy, of really supporting a patient to identify and assess their needs and feel confident in asking for help, in asking to be connected to services. But so much of that again is dependent on the relationship with the health professional, and having health professionals who are really diligent around the routine assessment and screening.
Yeah, I think on go ahead, Chris.
No, Christian, please.
Okay. Yeah. Thanks. So I think we as a physician as a physician perspective, I think we need to be trained. This is really important, and in communication, this is something really, on my opinion and my experience, is physicians need to be really trained in communication, how to talk to patients, how to talk to family members, how to express compassion. This is, I think, cancer become more stigmatized because sometimes healthcare professionals, we increase, the stigma, anxiety, and depression by the way we behave in front of our patients and families. And we make cancer and more, as from the testimony of Chris, when they say, oh, go to the lab. So where is the lab? How maybe was it difficult for the physician to stand up with you, go with you to the lab? This is the lab, Chris. Can you take your blood? And then I will get the result on my. I mean, we need to. There is a need of education and training on the communication, and the physician need to be comfortable in a comfortable situation. To be comfortable to discuss in a comfortable situation. Cancer, it's a very uncomfortable situation, but physician has to be comfortable on uncomfortable discussion. And that need to be physicians to be trained and to develop more compassion and empathy to our patient and the family members. And based on my experiences, I came to I developed it to one of the tools to the book. I just put the link on the chats, and I'm happy you guys to read about it. About from my own experiences when I was really focused on the disease, not to the patient. And I didn't care even how patient feels, in family members feels. I was like, okay, this is your business. My business is just to prescribe and show what you need to do. But having this kind of conversation, how do you feel? How can I support you? Be just a human being, and how we can be able to reduce the stigma until, you know, when more medicine continue to develop to make sure that cancer will be cured in the coming years. But my understanding is we need to start from us. As I'm saying that as a physician perspective. Yeah.
I like what you said, Christian, and Nicole, to touch upon something you said. You said to normalize the condition. So I believe it wasn't that long ago when cancer itself had stigma. As even in Malaysia, some parts, there's still stigma with cancer. So I believe one of the ways that we can help remove the stigma is also to share stories, especially from the patients itself. If you have issues with psychosocial issues as well, your own testimony, your own story will help normalize it to other patients as well. We get scanned when we first started. That's what we did for cancer, and I'm sure with palliative care and with other psychosocial issues, we can also do that as well. Get survivors to share their stories and to share those stories out.
Fantastic. Thank you so much to all of our speakers. Sorry, Christian, over to you.
Can I add something? Chris mentioned something very important I've just learned from the letter mentor, Dr. Paul Farmer, was really stating about qualitative research. You know, every time when people talk about cancer, about 70 million people don't have access to cancer treatment, 60% of people, you know, dying with the cancer every day, and 20% of survivorship, and blah, blah, blah. It's all about numbers, but nothing about narratives. And Christian must mention something very important. We need that paradigm shift in narratives. Qualitative now has to be considered as the same as quantitative, because everything about cancer is about numbers. But we need that paradigm shift, that everything also, when you mention cancer, it's also about narrative. It's about stories. It's about qualitative research. Yeah, thank you, Chris, for mentioning that.
Excellent. Thank you so much. Thank you so much, Christian, Chris, and Nicole, for that. I think it was a really excellent response, and I really like the idea that actually a large part of what we've got to do over the next years, decades, is really kind of change the narrative and change how we think, to then change how we advocate, to then change how policy is made. So I think, kind of bringing the session to a close, I wanted to pose one last question to each of our speakers, and that is, what would you like to see change between now and 2030? So 2030, we've got the end of the SDGs. Countries have committed to implement UHC by that point. Whether we'll get there or not is another matter entirely. But what thing would you like to see change? And I'll let whoever would like to go first jump in.
I think I've just picked you at the post there, Christian, but you're welcome to go first if you prefer.
I think you can go first.
So I think, Rosie, it's such a great question, and I 2013 is just around the corner. So there's not, really 2030 is just around the corner. There's not that much time. However, I think we have already a really great momentum in terms of, our understanding and what needs to be done. I think, we've really, we've got really quite a robust evidence base for a lot of these strategies. And so what I would love to see is, some, meaningful implementation of what we already know, what we already have, as a great reflection of all the work that has gone in to getting us to where we are now.
Excellent. Thanks for that, Nicole. And Christian, over to you.
Yes, it's a very difficult question because there are so many wishes, and yeah, as Nicole says, 2030 is just it's tomorrow already, and on my understanding, I need to see more and more palliative care to be integrated in cancer care. When people mention about cancer care, to see palliative care, integrated directly in the language, and also wishing stakeholders, Ministry of Health in African continent, to invest more and more in cancer care, control, prevention, palliative care, and survivorship. That is something really moving on policies to implementation and starting for what we have. And two last points. One is I hope to, my wish also to see one day the UHC World Congress to be happening in Africa, because it's interesting when I'm traveling to the UHC Congress to see everything. When you talk about challenges of palliative care, it's talking more about Global South, but there is no any Congress of a UHC in Africa where most of challenges of cancer are part of the world is in Africa. And also it's quite difficult for oncologists, survivors, health professionals to come to the Congress when we have a visa issues, when, people from Global North can get access to visa and Global South struggling to get there. So how people can know about our experiences, how people can know about what happened in the ground, how people can know, apart from the website, what's the reality we have in the continent. So that's it's part of my wish on a universal health coverage as well, to have this kind of opportunity and event to be happening in the Africa continent when people can get access, because most African countries visa it's upon arrival, so people can come and present their experiences. And of course, the last point is to see Nicole and Chris. You are welcome in Rwanda.
Excellent. Thank you so much for that, Christian. Chris, over to you.
I would love to have the World Cancer Congress, visit World Cancer Congress in Rwanda, Christian. For me, I believe that everyone in the world deserves access to care. So, but this is both an issue of political will and, of course, funding. So, for me personally, I would like to see that LMICs, all the low and middle income countries in the world, be able to reach that health spending goal of at least 5%. Actually, probably they need more than 5%. But we must also look for, and I hope, better alternatives, better financing models will exist by 2030 to make UHC a reality for everyone. This might be an ideal dream, but we got to hope for something, right?
Absolutely. And you've got to aim high. I think it's aim for the stars, and when you land on the moon, you still celebrate. And actually, yeah, Chris, thank you so much for bringing in the financing piece, because I think it's been a part of the discussion that we haven't touched on as much. So I will not do our speakers an injustice by trying to summarize in 5 minutes what they've said over the last hour and 20, because I won't do them justice. But I think there are a couple of key things that have really stood out for me, and that I think the UICC advocacy team will be taking forward in our work around the UHC negotiations as they continue. I think it was excellent to hear about sort of the importance of changing the narrative, changing our understanding of how we approach palliative, survivorship and supportive care and that's sort of the Venn diagram of how those kind of map onto each other. The really important piece around making sure that the services that we're building are built around the individuals and the communities, using our global models, using our regional models, but really, as Christian said, adopting and adapting and encouraging countries to think about where they have their strengths, where they have those resources, and build on what's already there. And then I think the final piece that I've taken away is compassion, and the importance of having a compassionate approach to patients, the families, the care providers. And so I wanted to say a final thank you to Chris, to Christian, and to Nicole for joining us today and sharing their expertise, for being so forthright in their opinions, and for issuing me with a challenge to the UI and the rest of the UICC to try and bring the Congress to Africa. We'll see what we can do. And thank you to all of you, our participants, for joining us, for the questions. It really makes these sessions so much more rich. So I'm delighted to give you back a few more minutes to your day, but wanted to say again, thank you so much. And we look forward to working with you all to put this into practice in the next 7 years. Take care, everyone. And thank you very much for joining us.
Thanks, Rosie. Thanks, everyone.
Thanks, Rosie. Thanks.
Thank you, Rosie. Thank you, everyone.
Take care, everyone. Bye.